insulin levels are high, you will not have a good response to radiation. In fact, you can increase your risk of recurrence and more aggressive metastatic and morphogenic cells. So what insulin and sugar does to the cancer cells is desensitizes them to radiation.
Welcome back to the Smarter Not Harder podcast, your home to life's 1 cent solutions to $64,000 questions. I'm your host today. My name is Dr. Scott Schur, and every week, with a rotating group of a high council of hosts, including yours truly, we interview top experts in health, movement, psychedelics, fun pharma, enlightenment, performance, and much more. Before we get started, don't forget to hit the like and subscribe button below so you don't miss an episode. This episode is brought to you by Transcriptions, makers of precision-dosed, pharmaceutical-grade, and physician-formulated buccal troches that go up here. And also Health Optimization Medicine in Practice, a nonprofit organization training doctors and practitioners on how to optimize health rather than treat disease. In this week's episode of the Smarter Not Harder podcast, I interview one of my good friends, Dr. Nasha Winters. Dr. Nasha is a global healthcare authority and best-selling author in integrative cancer care and research consulting with physicians around the world. She has educated hundreds of professionals in the clinical use of mistletoe and has created robust educational programs for both healthcare institutions and the public on incorporating vetted integrative therapies in cancer care to enhance outcomes. Dr. Winters is currently focused on opening a comprehensive metabolic oncology hospital and research institute in the U.S. with the best that standard of care has to offer and the most advanced integrative therapies will be offered. We talked a lot about this actually in the podcast. This facility will be in a residential setting on a gorgeous campus against a backdrop of regenerating farming, EMF mitigation and retreat, as well as state-of-the-art medical technology and data collection and evaluation to improve patient outcomes. All right, Dr. Nasha Winters, hello. How are you?
I'm so good, and it's so good to be here with you.
We've known each other now for a while, and I've been on your podcast a little bit, or your training, I should say, for your clients or the people that you work with. And it's so fun to have you on our Smarter Not Harder podcast to talk about all the things that you're so amazing at and have had so much experience. I mean, since you were much, much younger, I mean, you have your book that you've written, you've done so much training with now all different practitioners. You were working with patients for so many years. And when we first started talking, the first thing that actually resonated to me when speaking to you was this platform that you developed called Optimal Terrain. I don't know if you still call it that now, but I would love to start there. So tell me how that all came about. How did you develop this integrative oncology platform that started with that piece?
Well, first of all, I love the name of your podcast, Smarter Not Harder, because I was definitely spending the first probably 25 years of my career, or 20 years of my career working harder, not smarter. And so I'm like, where were you when I needed you then? Let's just start with that.
Me too, ditto.
And I think a lot of people look at, where you and I are in our careers or in our work and what we do today, and they think that we just kind of woke up one day like, I think today I'm going to launch something and be really successful. No. and so, it's lots of iterations. But what has always been this common thread for me for well over 30 years now is this understanding that disease is not a single cause, a single event, a single target, and a single treatment. Somehow that was intuitive in me at 19 years old when I was diagnosed with terminal ovarian cancer, to the point where I was so ill that not even a standard of care option could be given. And it was like, go to jail, do not pass go kind of process then. In my search, when there was no way that I was being offered, the very first book that I picked up that started to change my mindset in a pretty profound way was called Quantum Healing by this relatively unknown person of the time back in 1991, Dr. Deepak Chopra. This man, I mean, he's like a household name today, all of these years later, but definitely he was not then. He was really new to the game, if you will. And so that led me into work by people like Candace Pert and Bruce Lipton and, kind of in the mindset piece. And then it led me on the rabbit hole of what is cancer? What is disease? And it led me down these pathways into metabolic and mitochondrial underpinnings versus genetic underpinnings. And then it led me down into these concepts of terroir, this whole idea of some simultaneous, dueling concepts and ideas of its time between Louis Pasteur and another doctor, Beauchamp, was happening at the same time. And we sort of went eeny, meeny, miny, mo, and chose the germ theory, which has become the dominant theory of how we think about disease and treat disease today. And so I sort of stumbled into sort of the underdog camps accidentally at the time of my own very critical crossroad moment.
Your underdog moment.
Yeah. And that's what sort of has set the table, if you will, for what I've been ingesting ever since. And so when you talk about where did optimal terrain come from, that idea, we no longer call the company or the concept optimal terrain. It's actually called Metabolic Terrain Health Institute and these other pieces, because we're expanding on it to reach a particular audience, if you will. But it has never deviated from that vision at 19 years old. And God, I'm going to be 51 the end of this month. So it's been a long time coming. And it's what's funny is these were our common languages for many, many centuries, if not millennia.
Right.
Until sort of Descartes came along, it's like, you got to separate it. And then when we made a few other changes along the way in sort of pathology and physiology and genetics, it kind of put us into some of these other very non-dynamic camps.
Sure.
And that's just been what's been running the show, especially the last, 7,500 years. And in particular in the world of cancer, where I tend to hang out in these days. And so that's sort of the background to that. And it's probably quite a lot. There's a lot of places we could unpack there, but I feel like just when you said, where did this kind of begin? It began there when I was literally, one of my patients has coined, in the depths of Save Your Ass University. That's what I was doing at the time, getting my doctorate in Save Your Ass University, which then later led to me becoming a medical student.
Sure.
And leaving, like I was really, my life dream at that point was to become a conventional medical doctor. That was my plan. My illness took me on a very different path. In that time of exploring and learning, I stumbled across this concept of naturopathic medicine. And back in 1991 and 1992, it was definitely not a popular place to think about going. In fact, none of my professors, I was a really, really good student. All of them envisioned me to be the top of my class in conventional medical school.
Sure.
None of them would write me letters of recommendation for the medical school, except for one. One of mine, and he was my biochemistry professor. And the reason being is because he also had a love, his specialty is natural products chemistry. So he had sort of a natural inclination of like, I think, probably living vicariously through me on one level. And the irony is, fast forward many moons later, after my graduation, after several years in practice, and after all the things I'd learned from how Save Your Ass University, as well as my medical training, as well as really amazing internships I did in very standard of care environments, everything from pain management hospitals, one of the most well-known pain management hospitals in all of Arizona, to working in an AIDS clinic and HIV center. So my immunology became like unbelievable, to working in addictions environments, working in geriatric environments. I mean, I did some really amazing rotations in a lot of different fields that really have informed my concept even further about terrain. And this particular doctor, PhD in biochemistry, who wrote my letter of recommendation, unfortunately, he needed my services at some point for his wife. And that experience, ironic in how he was the only one who supported me to go this route. And though she did not ultimately survive in the end, she lived a good 4+ years beyond her expiration date with an incredible quality of life.
That's amazing.
And her family, in fact, her granddaughter, who was very young when she died, she was 3 years old when she died, she is just getting ready to go to college, and she wants to be a cancer researcher. This is how impactful this experience was in their family. And so I don't think there's accidents that led on this very long lineage. And he and his family are still very, very near and dear in my life on so many levels. And so that's what sort of led to me going down that road. And then ever since, I'm just a curious person by nature. And I don't think there's one way to think of anything or to do anything. And so I'm constantly exploring and adding new ideas and new tools to my basket.
That's beautiful. That's a beautiful story with your advisor and the letter and that coming back full circle. I'm sure that was beautiful for all of you in lots of ways. And you're in a tough field, Nasha. I mean, cancer does kill lots of people. So,
Yeah, it's
and
not like everyone's like, oh, I love what no one signs up and says, I'm going to treat cancer.
Yeah. I mean, I went the conventional medical route, went to medical school, and I have friends that are oncologists and that are doing the conventional thing. And it's not an easy world to live in. But the good news is that there has so much happened in the last 15 or 20 years since I went to medical school, and certainly since you went to naturopathic school, that it's an entirely new world for people. And I think that what's beautiful about what you've developed is that it doesn't mean that you don't do regular cancer care, and that it doesn't mean you just do naturopathic, mistletoe, et cetera, which we'll talk about. Like that, nothing is mutually exclusive. And I think that's the challenge for people now, I think, and is to how to navigate this world, right? And how do you navigate with your oncologist? How do you navigate with people outside of the conventional world? When it comes to the terrain piece, just to go back there for one more second or for a couple more seconds, is that what I find is interesting here is that as you said, cancer is not just something that arises all of a sudden. This is something that takes years, if not decades, if not longer, to develop as a result of all these various things. And certainly genetics could be part of it, but we know that's not the big part for most people. One of the things that's been interesting to me is to look at what's going on under the hood, in the sense of what kinds of data metrics are you typically looking for with these people? Are you looking at vitamins and minerals and nutrients, antioxidant status? Are you looking at their gut? Are you looking at what are the sort of, because I know you said you're adding lots of different things and always adding, and this is what I do, as you know, as well. It's always about how you can integrate and add additional things that are happening in the world. But what are, if you had to give your top 5-ish things that you do for anybody that comes in, when you were seeing patients directly or with the trainee people that you're working with, what are the 5 things-ish that you'd say that everybody needs to be thinking about? Is again, this is not just about cancer, right? This is going to be much more, but not what I'm asking for here is not not the things that everybody sort of knows, get more sleep, change your diet, but what are those what are those data points that you typically look for in the people that you're working with?
Well, first of all, I can't do it in 5. I can do it in 10.
That's totally fine.
Okay, cool. And again, this is just my flavor of it. There are variations on that theme. I know you've met people like Dr. Paul Anderson. I think he's got 7 or 8 in his groupings, and others out there maybe have the 8 or the whatever. Turner talks about the 9 or the 10 things for radical remissions, and there's just a lot of things. So, but they're all variations on the theme. We talked about that even with what you're doing. There's a lot of synergy. What I'm seeing in cancer is what we're seeing in all chronic illnesses, what we're seeing across the board of sort of a common denominator. And in my 30 years of figuring this out and exploring different things, there's about 10 major drivers I have found that should be evaluated for each individual. And these audits, if you will, these 10 drops in what I call the mitochondrial bucket, are things that you can audit on yourself without even a specialist, without even someone trained in this. You can start there. And that's what the premise of the Metabolic Approach to Cancer book created out there in the world. And it's interesting because it really should be called the Metabolic Approach to Life or Health or Longevity or whatnot. But, cancer is what I focus in. So, so really simply, we go through the list here. Epigenetics is this big one. And you mentioned this already, that we're sort of taught to believe that, well, not sort of, we are absolutely taught to believe that cancer is a somatic mutation, that it is a genetic disease. When in fact, the research is very clear that it will be as much as 95% of the population not being genetic at all, and as little as 90% of the population not being genetic at all. And to think of that in another way, that means only 5 to 10% of all cancers are truly genetic in origin.
Right.
Epigenetic, however, is the above the gene, meaning that you're born with a particular blueprint, but you have the choice of how you play that deck of cards, how you rearrange the furniture in that blueprint room, right? And so that's the 90 to 95% of the things we do have control over. And then so we want to look at family propensities. We want to look upstream a few generations. We want to get as much information as possible to understand maybe what your vulnerabilities are and even your strengths, because we can work with both of those to make you more resilient across the board. That's sort of the canopy of all of this. And then quickly to go through, the next one is metabolic. And this is about the fact that you probably have talked about this study a million times, but a few years ago, we were all just horrified at the fact that less than 12% of Americans were metabolically healthy.
Sure.
Unfortunately, in a couple of short years, that data actually shows that 6.8% of Americans are.
I haven't heard that. Wow.
Healthy. We dropped that almost 50% in 2 years, and that's pretty horrible.
Thank you, pandemic. Yeah.
And just very specifically, so people understand what I mean by metabolic health, a lot of people think that's just like your weight or a blood sugar problem, but it is, weight to waist to hip ratio. It is blood pressure. It is your overall stamina. It is your fitness level. It is your cholesterol level and your blood sugar levels. Those are all metrics of metabolic health. But there are others that we explore. So like literally just looking at what you're eating, or using tools like ketone monitoring devices or continuous glucose monitoring devices, and even just blood tests and whatnot to evaluate that. So that's a big one, knowing now that your listeners know that there's only 6.8% of us are actually metabolically healthy. That means the rest of us have a lot of work to do.
Indeed. Yeah.
End up in needing somebody like me in the future, or you in the future. And then the others follow suit a little bit quicker and more obvious, which are environmental toxins. I mean, even IARC, which is a major third-party research organization that has no sort of industry-driven, influence, that are out there saying these things are known carcinogens, these things are possible carcinogens, et cetera. So those are like the types of things that we're being exposed to day to day in our environment that are new to us in the last, since World War II, basically. Many of these chemicals didn't exist before then. Then microbiome, my gosh, you were asking about that a moment ago. A couple of years ago, we would talk about microbiome and they just said, oh, you're just a woo-woo naturopath. And now Nobel Prizes going to this endeavor. We are understanding more than ever that we don't even respond to certain medications.
Exactly.
Impact microbiome. So our therapies fail if the microbiome is failing. And then we are sick because our microbiomes are failing. So it's like a crazy double-edged sword. And so we look at that. We look at the immune function. Again, we've been in an immune crisis for the last couple of years. And that's one of the things we deeply evaluate with our patient population. We look at inflammation, known as the inflammation nation. We used to die of infections, but today we die of inflammatory diseases. Now we're dying of both. Turn this around. And then we look at things like your circulatory system, which is huge. This is what in the cancer world, it's more around angiogenesis, but in general, it's about perfusion and oxygenation, which is your jam. So that piece. And then we get into hormone metabolism. This is so much more than just, do you have too much or too little of hormones? Because actually that means very little. It's sort of like the calorie means very little.
Indeed.
You've got to look at the context. You've got to look at how it's being metabolized. You have to look at how it's being processed and moved through the body. That's a really critical factor with hormonal health, especially given that we're all swimming in a giant swimming pool of endocrine disruption today.
Right, with all the toxins in the world.
Hormone areas, right? It's like, oh my goodness gracious. So there's that. And then the final two, stress circadian rhythm patterns.
Sure.
My goodness, who isn't dealing with that?
Sure.
It's like when someone doesn't think they have issues there, I think they're probably delusional or lying. And then down to the final one, mental and emotional. And this is the big one that no one wants to talk about, but oftentimes it is the barrier to changing the terrain, changing the expression, and reaching that level of optimal terrain, optimal health that we are all striving for.
Sure. Yeah, the biology of belief, right? This is not a small thing, for sure. And that's a beautiful list of things. I haven't heard you say them so eloquently before in one little, I'm sure you've said it many times before, but to dive into them a little bit in the sense of looking at, because we believe the audience for this podcast is going to be people that really want to, like your biochemistry major, really interested in understanding oxidation, reduction, vitamins and minerals, and aspects of these things. When you're doing this assessment with all these things, you're looking at data markers, looking at various testing results, right? So you're looking at signs of oxidative stress, you're looking at antioxidant levels, you're looking at gut health, gut markers, et cetera, all that as well.
And I love that you asked this question, and I'm glad you qualified and clarified who the audience will be, because just to give you an example, in my coursework for physicians, for clinicians, physicians, I spend an entire, I think at this point we're 12 hours of just recorded didactic hours on just how to evaluate, meaning test all of these things.
Right.
Okay. And so it is a deep deep ass dive. Like and the doctors, it's one of their favorite parts of it. It's the most overwhelming, but it's also it is the language, it is the fluent language that bridges integrative medicine all the way. It's what brings in the dialogues from the naturopaths, the acupuncturists, the osteopaths, the nurse practitioners, the PAs, the conventional oncologists. It brings us all to the table, and it's a common language we can all share. Mm-hmm. Also with this type of data, these types of blood tests, functional testing, even down to well-curated questionnaires like the Myers-Briggs or even the ACE score, the Adverse Childhood Events score. There are common denominators of our understanding and our ability to communicate whether something is in range or out of range. And so that allows us this place to start to unpack what is going on with the patient and to have a starting point and a means of assessing, is what we're doing working or not? Right. Where can we do better? Where are we missing the boat? Because so much people got really excited about functional medicine, integrative medicine, and they test and test and test, which is gorgeous. Yay. But they don't know really what to do with all that information. I'll just be really blunt, and I'm probably going to upset a lot of your listeners.
No, that's the key. Yeah.
It's the key. It's like, how do you actually interpret that data? And so that's what I'm teaching them to take in large amounts of data. Then I'm teaching them how to assess that data in conjunction with other things that are non-tangible, non-objective. So down to certain questionnaires and certain means of asking certain histories and picking up certain cues of words, and even where things show up from patterns from sort of Chinese medicine, ideologies, anthroposophical medicine, homeopathic, Ayurvedic, because all of these ancient wisdoms brought with them really powerful tools of assessment and pattern recognition and systems thinking, things that are really missing in today's standard of care. And the functional medicine, the naturopathic medicine, we do it a lot better, but we are still not weaving it all together in a meaningful, actionable way. And so that's what we work towards, is teaching the doctors how to first test, then assess, before you even start to think about a protocol or about how to address it. Because we're also very protocol driven. All of our fields, whether you're a naturopath, whether you're a conventional oncologist, whether you're a functional medicine doctor. And remember, protocols work on a particular bell-shaped curve.
Exactly.
Right? But I just seem to get all the outliers. Really, we all do, right? So we might be very successful with our protocols in about 20% of the population. But about 80% will fall on either side of that bell-shaped curve.
Some spectrum, sure.
Right? And so that's where, when we start to get into this very individualized, very focused, very curated approach, we increase our response rates and our outcomes exponentially. So knowing that, like, just because we actually are collecting the data to present this data. So I'm speaking a little preemptively, I suppose, to this, but to give an example, let's say we lumped all cancer patients into one bucket, all stage 4 cancer patients into one bucket. There is about a 5 to 12% chance of them still being here in 5 years for a stage 4 cancer patient. In our methodology, in the test, assess, address methodology, it's not even so much about what the treatment is, it's about how you are curating that information to make clinical decisions, and then following the data, not the dogma, not the protocols, not the ideology. Right. You're following the data to change things. We're seeing closer to 70 to 76% in our ranges of those folks still here in 5 years. That is a big difference.
That's not a small difference, Nasha.
That is not a small difference. And that is something that we know before we really get out there and start making these claims. We have to have the data. Right. We've got to show the data in a meaningful way that would be considered legitimate in the eyes of the standard of care beholder. And that's what we're also building out, is the database to show this. And so there are a lot of working parts here. We're building our network by doing the education piece. We're building the database to collect our research, because I am the N of one, but so are the so far 125 physicians who've come through our training and all of their patients, N of ones. And we're putting all that in some place, which will eventually lead to the build out of this hospital medical system, not just a place, but a system that can be replicated all over the world. So that's where we're going to this. But backing back up, when I think about the most basics of tests, because I want this to be tangible for your listeners, there are very basic places we start. We literally start by doing the Terrain 10 questionnaire, which really helps people unpack what their blind spots might be. And it's just sort of 10 questions about each of those categories we just talked about. So then you can be like, hey, I'm highest at this and this and this. So maybe you look at the top 3. And when we look at those top 3, let's say metabolic comes up, hormones come up, and microbiome come up. Okay, let's say those are the 3 that show up. How do I determine if that is in fact expressing. So an example of this is epigenetics. We never treat the SNPs, the single nucleotide polymorphism, or we shouldn't. We've had a heyday in the last 15 years or so trying to do that, and it's not successful. So a lot of doctors have kind of poo-pooed the idea of doing epigenetic analysis because they're like, it doesn't mean anything. Well, was the patient even expressing that gene? Even if they have a hiccup there, have they overcome it? Or do they not even have a hiccup there and they're having symptoms as if they have that issue? So like MTHFR is a really good example.
Sure.
The motherfucker gene. We call it that for a reason because, in fact, one of the things that always surprises people is MTHFR is far more concerning for folks than a BRCA gene. And yet we put all of our energy, all of our funding, all of our resources into this gene that literally does not have one iota of change on overall survival rate in patients. But an MTHFR, unbelievable limitations and unbelievable outcomes that are because of its very presence of being not working correctly. And so, for instance, for something like that, in any of these tests, when I talked about those three things that might be showing up, you have to test and see if it's actually expressing.
Right.
And then you have to know, is the protocol or whatever treatment decision we've made, is it the right one? Is it working? And is it done its job and now we can move on to something else? So for instance, if it's metabolic, we're going to definitely get a baseline insulin, C-peptide, hemoglobin A1C, because glucose means absolutely nothing. Absolutely nothing. It's so transient. It's so ridiculous. It so doesn't track with so many things. Yep. And there are so people, like my brother-in-law is missing several toes, has wounds and fractures that will not heal for years now. And he has a perfect glucose, despite the fact that he can't feel his feet, and looks like a metabolic time bomb. And I say this with absolute love, and I've said it to his face many times, but you cannot tell me that the doctors refuse to run a hemoglobin A1C on him or an insulin on him because his glucose is fine.
Interesting.
Because he knows how to fast and exercise before he goes in to fudge damn tests.
That's great.
So we have to take in a lot more data points.
Yeah.
Got to take in more data points. Yeah. And so we can do that. We can look at we can do all those things we talked about with the hormones. As I said before, it's not about what we tend to do is we tend to run a serum test and we go, they're normal, or they're off range, or they're low. Guess what? They should all be low in your serum. They should always be low because they should not be floating around in your bloodstream. They should either be in receptors or out of the body. So when we have doctors who are treating women and men's hormones based on blood tests, we're treating fictional unicorns at that point. Okay. There are other tests that are better suited to evaluate how the patient is utilizing those hormones, processing those hormones, excreting those hormones when they've been used to their level, and then to see if there are certain places where they're getting stored or utilized in an improper way. And there are definite epigenetic potentials that make hormones more difficult in some people than others, endogenously as well as exogenously. So we teach the doctors how to evaluate that. And with the microbiome, I might upset some of your listeners here. I got so excited and hopeful about taking certain tests that you could send off your poop and know exactly what's going on with you and know what diet to eat and what supplements to take. But guess what, guys? You can change your microbiome in 3 days just by going, today I'm going to be a vegan for 3 days. Today I'm going to be
just get on an airplane.
Yeah. Today I'm going to just fast for 3 days. Your microbiome changes that quickly. So we need to look at some of the other byproducts. And one of my favorite tests for really looking at what's going on there is an OAT test, an organic acids.
Yeah, organic acids. Sure.
Way more. And you even talked about how do we effectively test for oxidative stress? That actually is quite helpful. Even in that testing, and certain inflammatory markers like C-reactive protein should be standard. Right? In everybody. In fact, CRP is so critical in the cancer population. If your CRP is elevated at the time of your diagnosis, you have a poorer prognosis. If you have an elevated CRP at the time of your diagnosis and at the time of treatment, you're going to expected to have worse side effects and more drug resistance. How the F are we expecting to help these patients when I would say 99.9 of them have elevated CRPs at the time of their cancer diagnosis into their cancer treatment? It's a stinking miracle we have any success in conventional oncology alone.
So that's the idea again, that this just didn't happen de novo out of the blue. This has been something that's been brewing related to significant dysregulation from energy metabolism, from gut health, from everything else in between along the way. You piqued my interest on the hormone side of things because you're talking, the fictional unicorn is fantastic. I love that. So tell me a little bit about how you would test hormones in somebody that came in if you're not going to be using blood tests. Are you using urine, saliva, or what are you doing?
First, I'm looking at a really good history.
Of course.
That's one of the things that physicians historically were meant to be, were incredibly good historians and story collectors. And our current medical system does not allow for those very effectively. Okay. So I really do a deep dive into people's hormonal health. Like, tell me about your menstrual cycle, your fertility, your libido, your, your skin, like for women, do you have hair growing in weird places? Do you break out easily? Like, those are clues to me that there are hormone patterns happening. And then we can sort of just guess by the symptom picture and the clinical. This is what the other thing is today, because everyone can dilapidate and can basically wax anything. You don't know the population that's walking around that actually has polycystic ovarian syndrome.
Sure.
Because they can hide all that really well today.
Sure.
Right?
Yeah.
And so there are people that would have natural beards if we were not have access to what we have access to.
The bearded lady was real. Totally.
But exactly. It is real. It's very real. And it's more real today than ever before. So, this is what's so crazy. And then same thing with men. It's like men are walking around, honestly, with bigger boobs than me on a regular basis and starting at very young ages. These are not normal things, right? And male pattern baldness is happening even more and more in both sexes. And I mean, there's just so much stuff that's happening that I'm like, how is no one questioning this? So just a good clinical history is very, very important. And asking people the hard questions, like, do you have to dilapidate? Do you have to remove hair from unwanted places? So things like that are part of the evaluation that is an absolute must.
So along with the laboratory testing as well, you're doing a really good history and then correlating it together, right?
You got it. And in that history, when you talked about, I'm definitely looking at the whole endocrine axis. I'm looking at everything. I want to know what's going on with the thyroid. Because if the thyroid's not working, many other hormonal systems aren't working. If the adrenals are fried, nothing's working. If the if insulin is funky, nothing's working. So I call them the 3 S's: sugar, stress, and sex. And that's the sugar is your insulin issues. The stress is your cortisol, and the hormone, the hormones is just any of those. It could be androgen, it could be estrogen, it could be any of those pieces of the sex hormones. And so we look at how those are relating. And then specific to testing for the hormones, I really do like to get epigenetic SNP testing on this because I want to know how people metabolize. So simply put, the ones that are well characterized in the literature are CYP, cytochrome P450 enzymes of CYP, 1B1, 1A1. Those are very critical to how we metabolize our hormones. We also want to look very closely at COMT, which is the catecholamine response, which is very, very impactful on how we move our hormones through our body. And interestingly enough, so are the VDR and the CYP2R1, which are the way we metabolize vitamin D, which is huge on all of those 3 S's I just talked about.
Of course.
And so when we look at those, we already then go, ooh, these people already have problems with how they deal with their endogenous hormones. And when they do exogenous hormones, be it intentional, they're trying to manipulate things from the outside in with a bioidentical or well-meaning approach, or whether it's unintentional, be it from overexposures of chemicals and endocrine disrupting hormone, things like glyphosate and whatnot out there in the world. We're eating a lot of CAFO raised animal protein and whatnot. Those are the places we have to discern. But we can see that information, metabolite information, via urine testing is my favorite approach, but you can definitely see more patterns of people's cycles and hormonal shedding and utilization in the salivary. But when I'm looking at, for me, I like to look at the urine to really see how they're breaking things down. And then in the urine, we can really see that relationship of when we think about 2-hydroxyestrogens and 16-hydroxyestrogens and how they relate. And then 4-hydroxyestrones, which are like the known toxic cancer-causing quinones, that is all CYP1B1 dependent. Right. And so again, I'm helping doctors weave together lots of different data points to know how to make it come together as a beautiful story. So those
That's
are just
awesome.
examples that we're looking at in this piece. And then coming back to like the microbiome, when I got excited about these tests, I realized how quickly we check things. So I also you need a good history. You need a good diet diary, a macronutrient counter, and you need to ask people how you feel. You also, I have them do things like the beet challenge test, right? Like basically look at a clock, eat your beets, look at the clock at what time you eat them, and then look at the clock when you see red on the other side, right?
Sure. What do you tell your?
Yeah, I mean,
how long is it supposed to take?
We call it the beet challenge test. And so
I love it.
The transit time test.
Yeah.
So if it's faster than 12 hours, you are like, it's shooting through, you are not getting any of your nutrients.
Sure.
If you never see it again, that's a problem. Or if it takes longer than 18 hours,
yeah,
that's a problem. And then another interesting thing, if you see pink in your urine after eating them, that's another indicator. So for example, if you see pink in the urine when somebody eats beets, they have problems with B12 and B12
interesting.
synthesis. So very interesting. And so you can really do a lot with just these simple in-house tests. Your patients are going to have to become very familiar with their poop and the timing of their poops and be talking to you about their poops.
Why hasn't that happened on TikTok yet? We don't have a beet root. We don't have a beet challenge. It should be there, right?
So weird. I could tell. Maybe that's my. That'll be my claim to fame.
That's your inroad to TikTok right there. Millions of hits showing everybody showing the color of their poop and their color of their urine. So
well, apparently that would probably work better because I could literally tell people I have the cure for cancer and they care very little. But when I show pictures of my cats or my dogs or when I'm eating, people go crazy. So I'm sure if I should transit time, it would change the world.
I think that the gauntlet has been laid, Nasha. At some point, it's got to be there. The beetroot challenge is it's got to be like trademarked. All of it's got to be all there for you.
Do you think I can make like the bulletproof empire with beet transit time empire? I think I'm doing it. Let's do this.
Yeah, let's do it. Let's do it. I'm not your first participant. You can find somebody. Maybe I can.
Expecting that.
I could we can do it with my kids or something, like, hey, here, ladies, just try the beets. Let's see how long it takes.
And then this is the other thing. Remember that you ate beets because then I don't.
Yeah, that's also scary for people.
Heart attack around this. Yeah.
That's also scary for people when they have their beets and forget that they've had their beets and they're pooping out blood. Yeah, it's a problem. But it's a happy surprise when you realize, oh, it's just beets. It's okay. Still get your colonoscopies and your screening, please, everybody. But anyway. Yeah, I had the same reaction when some of these gut testing came out as well, Nasha. I was like, well, this is going to be great. We're going to have all these different markers that we're going to notice and we're going to see. But then they started making all these claims as to what you could find in your stool and how this correlated to what you need to eat in your diet and your food sensitivities and all these other things. And really the data is not there. Yeah, I mean, I agree with you that I think you can get some really good data from stool analysis. You can look at commensals, you can look at overgrowth, you can look at metabolic profiles, your short chain fatty acids, you can look at how well you're digesting your foods. But also doing that in correlation with organic acid testing is really important because that's when you see the metabolites of all these bacteria, yeast, and everything else that you get a sense of what's actually happening over a longer period of time. As opposed to a stool test, like, as you said, can change in a day, 3 days longer. Our microbiota are so adaptable to the changes in what we eat, the changes in our environment, the changes in how much we sleep. And that's also the problem with with a lot of different trials that have been done look at, like you mentioned this earlier about there's certain drugs that are actually activated by our gut microbiota or inactivated by it. And so I can't remember which chemotherapy drug it is, but there is one, right? That like is
Yeah. Cyclophosphamide.
So what is it that if you have a certain type of bacteria that it's activated, or if it's not there, how does that one work?
If they take antibiotics basically within 6, so there's two trials that come, actually there's a lot more than that, but two that stand out in my mind is antibiotics taken within 6 months of an immune therapy almost just aborts the effect of the immune therapy. So that's a whole nother animal.
Wow.
And then there are information about it creating kind of prodrug, like there's some about how you can create prodrugs, so increased toxicity depending on your microbiome print. And then there are others that show very impact on the actual absorption utilization of the chemotherapy. And I believe cyclophosphamide is the one that they've studied the most. And there are different, depending on the microbiome, can either sort of make the drug more toxic, like overly effective, or completely under. So it's got a two-edged sword to it. It's like you need the Goldilocks for it to work well. Yeah.
Wow, that's crazy. I mean, I knew that some of the research on the underactivity of certain drugs depending on the microbiome, but I didn't know about the overactivity as well. And so you mentioned immunotherapy. This has been the huge thing over the last 10 or 15 years now, and how we're treating cancer in a lot of different ways. And I know this is something that you're very well versed in. I didn't realize that is it all immunotherapy is gut? There's something that's going on in the gut there, or do we think it's just a subset of the different types? Or
And how lovely that you brought this question, because as a kooky, wacky naturopath, we've been saying it's all in the gut, guys. And we've known for so long that our gut is the major immune system.
Right.
Our body. There's the belief, and now even conventional wisdom says about 80% of our immune system is in our GI tract. So the gullet, the lymph, there's all these lymph manipulators and communicators that are living in our GI tract. And so if the gut's not working, our immune system is typically not working. And if you heal the gut, you tend to also heal the immune system simultaneously. And so everyone is excited about the immune therapies, and especially your listeners have probably heard this trial that came out, just 6 weeks ago, maybe a little bit longer. To just give a little interesting background, the Dr. Luis Diaz, who was the primary investigator on this paper, this trial, this experiment we'll talk about here in a moment, he also wrote the foreword to our mistletoe book. So that's a really cool, this is going to be a nice little segue into that. But Dr.
Awesome.
Luis Diaz has always, the things that he's always been fascinated are epigenetics, immune system, immune modulating, the immune therapies. And it was even him giving me the tour of Hopkins, talking to me about that there's he's now the head of solid tumor oncology at Sloan Kettering. So, he's this big damn deal. But he's the one who was telling me, they give out a Coley's award, a Dr. Coley's award every single year for innovations in medicine. And yet no one even realizes that Coley's, as in Dr. William S. Coley, said that I might be mistaken on his middle initial, but he was the original, the father of immunology, of immune medicine oncology. And so it's just a fascinating thing that this Coley's toxin, where he was giving an injection of basically pus to tumors that cause these massive fevers that resolve the tumors and the patients survive, the unsurvivable, that was done in standard of care through the 1960s.
And then chemotherapy.
Right. Yeah. More effective. And then it's let's bury that, pretend it doesn't happen. And then we fought. Dr. Allison, who ended up winning the Nobel Prize in the checkpoint inhibitors just a few years ago, who they put, he's a quack, he's a freak, and just the man was blackballed for years. And it took 20, 30 years for his work to come. And now his work is the $1 trillion answer to the $50 problem or whatever it is today, that what we're coming down to. But I tell that story because when this study came out that Dr. Luis Diaz published, he had I think it was 18 patients, all colorectal cancer, all of them that he put into complete remission, every single one of them, which is unheard of, right? With a checkpoint inhibitor, with an immune therapy. Everyone read those headlines. Everyone was going absolutely crazy. But what I knew was to read deeper. And what I know about Dr. Diaz is I know that, yes, we're all excited and celebrating what he put out there in the world. Also know that the intention of that was to stir up the questions and the curiosity to go a different route. Unfortunately, everyone now thinks this is the magic bullet for everybody.
Sure.
And with the thousands, and I kid you not, thousands of email inquiries saying, can you get me into this trial? Can you get me in on this? Can you give me this drug? And the thing is that there was very specific parameters of these patients. This is precisely what I do for a living, is what Dr. Diaz was able to do with these 18 patients. He was able to look at, they were all under the age of 50. They all were treatment naive, no standard of care. They all had Lynch syndrome. They all had a particular genetic mutation. If we took that a little bit further, there is an MD Anderson scoring system that came out to look at people who would have good or not so good responses to immune therapies. There are 7 questions to that. Number 1 are they over the age of 52? Number 2, do they have a 0 ECOG score? So do they have any problems of any kind dealing with day-to-day existence? Number 3, what is their lactase dehydrogenase? Number 4, do they have any liver problems? Number 5, is their neutrophils very elevated? Number 6, are their lymphocytes very low? And number 7, are their platelets elevated? So this is the parameters that if just by the patient population he chose, they probably at most had 3 yeses to those 7s. And when you start to get above 3 yeses on those 7s, the patients become less and less responsive to immune therapy and even more endangered. They can have a lot more terrible side effects and even irreversible side effects and even death. And so this is the place that I know as a clinician and what I've learned in this field to go deeper. And no one's talking about that. They're just like, Keytruda for all my friends. And that's how this is playing out. And what's going to happen is we're going to have this population and we're going to see the 20%.
Same thing. Yeah. Yeah.
And so what I got excited about when this came out and what I keep hoping I can grab and change people's, like shake people awake, is to say, this is how it should be done for every single patient. Every single patient should be evaluated and screened for exactly what treatments are appropriate. And this, my friends, is the future of integrative oncology and integrative medicine in general, and what we're developing at the Metabolic Training Institute of Health and Research Institute, where every single patient will be analyzed and categorized into what potential therapeutic interventions from conventional standard of care, repurposed standard of care, blended standard of care with quote unquote alternative care, and which ones fit best at what time, at what dose, for what duration. Right. And that is where we see the different outcomes, just like what Dr. Diaz saw. What he was able to show the world is that this is possible for everybody.
Right. It's individualized care, right? But it's going much, much further than what we would typically do in the conventional world. It's beautiful, Nasha. One thing that came to mind as you were describing your whole place in Arizona that's going to be coming at some point soon is people can shift, is right, in the sense that somebody comes in with a score, this MD Anderson score of X, but over doing some terrain work or your metabolic processes or another type of program that's similar, you can likely shift how people are able to tolerate things like immunotherapy, conventional chemotherapy, alternative types of means as well, correct?
Gave me chills. I love that you picked up on that, because that is exactly it. This does not mean absolute no or absolutely yes to something. It says, here's our starting point. How can we enhance the response to whatever therapy is chosen?
Right.
Whatever therapy. So for instance, things like mistletoe or low-dose naltrexone, for instance, or any immune modulating therapy, Keytruda included, okay? If your vitamin D levels are low, you're going to have a less than stellar response, if any response at all. There's just one example. You know, if your insulin levels are high, you will not have a good response to radiation. In fact, you can increase your risk of recurrence and more aggressive metastatic and morphogenic cells. So what insulin and sugar does to the cancer cells is makes them desensitizes them to radiation. Those are just some of the examples. And it's like, how amazing. I mean, again, when you think 6.8 people are metabolically healthy, and then how many of those people are going in for radiation, they're fucked. I mean, can I say that here?
Of course you can.
You can beat me. But I'm like, that's like, it makes me angry because it doesn't have to be that way. Wouldn't it be great if we got them ready? If we got them, like, even if we had a couple of days to a couple of weeks to get them quickly into even
concurrently
using exogenous ketones to get them started, and a little bit of fasting, even just intermittent fasting, not even aggressive. Most of these people who are metabolically broken can't even fast 13 hours a day, for crying out loud. If we can even do that with some exogenous ketones on the days of their radiation, we actually improve outcomes just from that simple lowest hanging fruit. And you can take it from there to make it even better and better and more pronounced. But we are ignoring these really impressive opportunities to enhance standard of care and re-envision the way cancer should be thought about and approached. And all chronic illness should be thought about and approached.
Right. And that's the thing. This is not just about cancer, of course, right? But one thing you mentioned that I would like to talk about for a minute is sugar, because this is obviously something that you've talked a lot about, and our colleagues, Dr. Dom and Tom Seyfried and others. And one thing that I get a lot, and it's a question that I always refer over to you guys as integrative oncologists, as a hyperbaric doc, is when is it the right time to avoid sugar? And when you have a cancer diagnosis, there are some tumors that are not as hypersensitive to ketones as others. And some questions to me. This is kind of for personal gain, because I often get like, oftentimes we think of like the ketogenic diet, we're talking about exogenous ketones, that most cancers, when you're starving them of glucose, are going to do poorly. And then you can add on other oxidative therapies like mistletoe. We'll talk about that in a minute. You can add on hyperbaric oxygen therapy, which is what I do, obviously, as you know. But there's not always that direct correlation in the sense that what are the outliers there? What do the people have to know? Even as a clinician, this person should not go on a ketogenic diet, for example, versus this person that maybe should.
So good. So good. And I literally just did an incredible interview, and you should have him on, with Dr. Ahmed El-Saka.
Okay.
He's probably the most prolific researcher and publisher and clinician in the field of metabolic oncology. He has done some incredible research, incredible understanding, and the many conversations he and I have had over the years is that there really is a way to determine what dietary intervention is the best, and to please, I beg people to forego the influencer recommendations or the all or none, or even some of the well-meaning metabolic mapping, websites that are out there telling people, oh, if you've got this type of cancer, you never eat this way. If you've got this kind of cancer, you only eat this way. Like, those are really dangerous games to play in. And it comes right back to the test, assess, address, don't guess.
Gotcha. Yeah.
So simply put, for you and your colleagues, 70% minimum, 90% is probably more likely. And in my clinical practice, I would say maybe even higher than that, from what I see, because I test, our cancers are glycolytic. They want sugar, right? Especially earlier on, before they start to really mutate and go crazy. So basically, the more treatment naive they are, the more metabolically broken, as they become more over-treated with over-oxidative therapies and therapies that are damaging the mitochondria even further, that's when the cancer cells get desperate and start to metabolic shift in their requirements for other nutrients. So that's the simple term. But what's really cool is one of the things that Dr. El-Saka taught me, and I was doing it, but I didn't understand exactly why. But he basically comes in when you have that question about, do we need to worry about methionine restricting here, for instance, which is, like an essential amino acid that we need to have for our healthy cells to survive. So you do not ever, no one should ever get on a methionine restricting diet for any period beyond a few weeks at a time, if that's an appropriate diet for you. But what we do is we start with a homocysteine test. Okay. If the homocysteine, he likes 9, I like it at 7. I'm a little bit more aggressive on my functional ranges for my homocysteine, but I want my homocysteine levels to be as close to 7 as possible with these patients. If it's elevated, which we see a lot of this in people, because about 70% of the population are dealing with methylation SNPs like MTR, MTRR, MTHFR, et cetera. So we need to, rule that out. And so for 6 days, he says that's the life cycle of how long you can basically clear out that homocysteine dumping. For 6 days, you put them on methyl factors, basically. So you put them on things to lower homocysteine, like your B12s, your folates, your, whatever.
TMGs, sure.
Right. Yeah. You do that, and then you retest the homocysteine. If it came down even a little bit, this is a methylation problem, and you need to get them aggressively on a low carbohydrate diet.
Interesting. Okay.
If it comes back still elevated, you are dealing with a cancering process that is likely a methionine hog. And then there is a particular protocol that is pulsed and cycled in a way that's safe and effective for the patient, that you basically enrich them with things like hyperbaric oxygen. This is his protocol, for 2 weeks.
I need to talk to him. Sounds good.
I know you do. So I want you to hear this here. I want to say it first to all your public. He will have a Nobel Prize. I have no doubt in my mind the work he's doing. This is like this tip of the iceberg of what I'm telling you, what he does.
So awesome. Okay.
He's enriching them, charging the mitochondria. Therapeutic ketogenic diet, hyperbaric. He's like bringing all these things in, and then he methionine restricts them. He basically puts them on a vegan, but low carb. He says this is very important, low carb. So please do the fruitarian diet that some people are telling you to do for this. And so he basically puts them on up to a couple of weeks on that, but he's testing the homocysteine. And once the homocysteine normalizes, he slowly weans them, still monitoring that homocysteine, back onto a ketogenic diet.
Interesting. Okay.
Remember, ketones are affecting much more than just low starving cancer of glucose. It's impacting all the train 10 drops in the bucket, ketogenic diet pulls the levers on. It's changing the microbiome. It's changing HDAC expression and epigenetics. It's changing hormonal modulation. Like it's all the things, right? So he would tell you, as the most prolific researcher in this field, that likely you're the best place, if you have to guess, to start is going to still be carbohydrate restriction in all of your patients.
Sure.
And then these nuances of when and how to utilize these other therapies, those are based on those of us who are testing and looking at this. And
doing
then
integrative oncology. Yeah.
Yes. And he's like RAS mutations are always like, he says, I almost feel like I can say that they're always glucose, driven. And so like and we've known this, like KRAS mutations are one of the few that like, so we can really with confidence say a ketogenic diet and IV vitamin C really knocked this one out of the park.
Okay, you did it perfectly. That's perfectly, because I want to talk about oxidative therapies. And so you mentioned mistletoe, and I know you just had a book that came out recently. So Labors of Love, as we were talking about prior to the podcast starting. So let's talk about oxidative therapies, right? Because one of the things that, and also a little bit as a dovetail on this, and I'm sure you can do this well, is I get a lot of questions from clinicians as well as my patients. Well, like I'm on antioxidants because I need them for, because my blood levels are low. Should I stop on my antioxidants while I'm on oxidative therapies? Or how do you approach somebody with this kind of this conundrum, right? So like antioxidant, oxidant, how do you work with somebody in this capacity? What are your thoughts on that?
Sure. Well, first of all, this is where you need either get Dr. Osaka on, or I'm going to, toot this horn, but my husband is like probably the best of the best when it comes to,
Go Steve.
He hates the word oxidant or antioxidant. Like he goes batshit crazy as a chemist. He's like, it's redox reaction.
Yes.
He's listening outside the door right now. He's probably running around screaming redox in the background. I'm not kidding. I think it's seriously
that's all it is. That's all I'm doing in hyperbaric therapy too, by the way. That's all I'm doing.
Get a rise out of him. That's what we say, right? Yeah. It's just like antioxidant. It's just so much fun at parties to see what happens.
That's great.
And also like his expertise is also the epigenetic expression, how OAT testing, epigenetic testing, and these redox pathways all interface. So that would be a fun conversation.
Oh yeah.
Bill Saka as well. In fact, he and I, when on this interview, I was asking him, what do you say to the folks who are like, absolutely no N-acetylcysteine or CoQ10 or green tea extract in the midst of a kill phase, an oxidative treatment phase of cancers? And he goes, well, first of all, I mean, you can do that strategy, but it's all about redox. And he's like, basically the cell is smart enough to modulate what it needs when it needs it. And there's not any one of those types of therapies out there that will override the oxidative stress of something like chemotherapy or even hyperbaric oxygen.
Of course, yeah.
And it's like the conversation around vitamin C. Orally dosing vitamin C is quote unquote antioxidant. Oh my God, forgive me. But it's like it's going to have a different mechanism of action than when you go high dose. And the high dose is when we get into actual cytotoxic reducing processes.
Sure.
And so there is this sort of gas pedal, and even just timing, like how I approach it with patients and physicians is, yes, there's literature out there suggesting that these things can quench the desired effect, but there's also research out there about equal that it doesn't have a damn thing. And so clinical practice and the art of this say that if you want to be safe, I tell people just avoid it on the day of those treatments.
Those oxidative therapies, sure.
Because
yeah.
I mean, the oxidative therapies are short half-lives.
Right.
Short-lived. And so are these other oral agents and even IV agents.
Right.
And so you can, if in doubt, spread them out.
Nice.
Spread them out.
That's your other TikTok. That's it. I like it. We got two TikTok videos for you.
There we go. I'm taking notes. There it goes.
Yeah, I mean,
we'll use our revenue to fund our foundation.
Please, all the money to you, Nasha. Build that cancer center, or cancer, whatever.
Yeah.
The cancer center. So, but this is one of the things that I get a lot too, because, the work that I do in health optimization medicine is looking at that foundation, looking at vitamins, minerals, nutrients, and antioxidant or redox status, let's call it for Steve. And so look, all I do in a hyperbaric chamber is redox as well. So, I mean, come on, that's what people tell me.
Yeah. World, right?
Right. Yeah. So, but what happens if you're measuring and you see that somebody has significant levels of oxidative load, their antioxidant levels are low, and you put them into a hyperbaric chamber, for example, I could run into trouble because they don't have the ability to balance out that oxidative surge with oxidative stress with an antioxidant surge. So I often feel like there is a role very likely to be on antioxidants if you need them, not just taking them willy-nilly, but actually don't guess, but test what you need, but then potentially not using them on the days you're getting oxidative therapies, like you said, whatever that line you just said, which was great. Say it again for everybody. What was it?
When in doubt, spread them out.
Spread them out. There you go. So one of the things that was interesting to me also is, would there be a role, and maybe this is from one of your colleagues that would know more, but like, is there a role to over antioxidize, and to the point of so that you downregulate your body's own ability to make antioxidants as a result of that? I don't know if you've run into that at all.
I have, and the one that comes to mind really quickly, and this often surprises people because they don't think of this really as an antioxidant, a redox agent, is vitamin D.
Yeah.
So we can take too much vitamin D and basically suppress our immune systems, which is a very powerful strategy when you're dealing with an autoimmune flare or a flare in response to a standard of care immune therapy, such as Keytruda.
Yes.
I have had people, we call them, vitamin D or autoimmune rescues with massive doses of vitamin A, vitamin D,
become pro-oxidant.
Fish oil. Fish oil is another one that does this.
Interesting. Okay.
High doses of fish oil will also suppress the immune system. And it's in this exact arena of this redox reaction that it's actually impacting. And so that's where you use those like a surgical intervention, like really acute, get in there, get out. And so that's what drives me crazy when we do have some people out there that are like putting people on really high doses of things. They just don't understand what it could override or underride. And that's why, again, you can test that. You can easily see from just a good history of the patient and some basic labs. I mean, our monthly labs are always, we have this massive kind of panel of onboarding, but what we check every single month with every single patient going through treatment of any kind, while they're actively cancering, we're looking monthly at their labs. We're looking at a CBC with differential. We're looking at a metabolic panel, and we're looking at what my patients have coined as the trifecta, which is the C-reactive protein, the sedimentation rate, and the lactase dehydrogenase.
LDH, sure, yeah.
That collection of data, which is about $40 a month at
not
a
expensive.
lab, is literally far more sensitive and telling than any cancer marker or even any imaging. Because what people don't understand is we put all this weight on the imaging, and yet you need to look and see if that mass is doing anything. And there are, yes, we can do like an FDG uptake PET scan to see if it's taking up glucose, but you could also do it could also be taking up methionine. It could be taking up other things, and we only test for one.
Right.
So it might be like, hey, it looks good right now, or it looks like it's, holy hell breaking loose. You can't really know that without doing further testing in the laboratory assessment and the patient history and what's going on there. You must look at a bigger picture. When we hang our hat, which we do in standard of care, on what's going on in the imaging, we kill patients. Yeah.
And then the other thing is that oftentimes you can see things shifting, sometimes in the quote unquote wrong direction, as you're initiating oxidative therapies or other therapies together, where you can get the wrong picture by looking at other markers. I'm sure you've had that experience.
And if you don't have the context, which is why we train our physicians and we train the patients to have very good communication and historian issues. When we meet with them, we basically say, tell me the chronology. When was your last treatment? What treatments were those?
Right.
So for instance, if someone's getting a mistletoe IV or subcutaneous, and they're new to it, they've been mistletoe naive, I don't want them doing any imaging for the first 7 or 8 weeks, because you can get pseudoprogression show up on the
Interesting. Imaging. Why do you think that is?
Pardon?
Why do you think that is? Do you know?
Because it's stimulating immune reactions, and it's causing swelling, and where you see that pseudoprogression is almost always in the lymphatic system. So that's, of course, the housing of this. But that's even true when you're doing standard of care immune therapies. Everyone has learned to accept that, but they aren't reaching it into other arenas.
Right.
And so that's one. And then the other thing is, when I'm looking at labs, I'm like, please don't go and do a day of 8, your low, your fractionated chemotherapy with your hyperbaric oxygen, your high dose vitamin C, and then go run labs that afternoon or the next day. Don't. It's going to look bad. And you should, you should be seeing things like tumor lysis, right?
Right, exactly.
I teach the doctor how to even assess for tumor lysis or even cytokine response, storms. Like, those are the things that they're taught to navigate and understand. What am I actually looking at? They're taught to understand the difference between progression and pseudo progression.
Sure.
And so those are the things that are not taught in standard of care oncology.
Yeah, there's no such thing as progression and pseudo progression. In fact, I think you're the first person to use that term that I've heard before. But it's a great term because you just, like a lot of times when you're doing all these additional therapies, you're going to have shifts and you don't really know what they mean for several weeks or not months later. But you're looking at those labs, like the easy ones on a regular basis. It really does give you a nice feel of the overall progression, right? But knowing there's going to be ups and downs along the way. I mean, that's just,
and that's what we
nature.
do when we track. You don't look at one point in time and go, oh, this is really good, or oh, this is really bad. You got to look at sequential. Because it will change. And then that's where we even start, when we see a few, we're like, let's just make sure we shift them either a few days before or a few days after these therapies. So we know what we're actually looking at. Are we looking at treatment response or are we looking at disease progression? And so we can see that very easily. And again, these are not taught in naturopathic school, in conventional medical school, in oncology circles. These things that I've learned. I've literally had to go out into the world, literally all over the world, and meet and intern with and ask questions of and explore within myself and tens of thousands of patients of how to come up with this methodology.
Right. Like, and this is your school now, right?
This is my school. This is me. This is School of Safety. This is Xavier House University that has now got satellite universities.
It's evolved into having people that are going to have Nobel Prizes and things like that, and other people in your network and amazing surgeons around the world and new types of scans and people that you and I have spoken about and with and to at various locations around the world. And so, I mean, I think that's really exciting, Nasha, because I think you've already mentioned this on several occasions, but the ability to collate and sort of make sense of all this data it sounds like that's really where you're going with all of this. And you mentioned earlier with stage 4 cancer, somewhere about 6% survival now, like to 70% potentially, something like that. And like, that's huge. So tell me and tell us about this amazing place that you're looking or you're starting to build soon in Arizona.
Yeah. And so one of the things I want to just point out before we leave and talk about that is that what we're learning, this is what I think is so exciting and hopeful on the horizon of integrative oncology or oncology in general, even standard of care oncology is waking up to this point, is that cancer is a manageable disease process. Okay. It's no longer a get out and kill and destroy and napalm the field with maximum tolerated dose approaches. It's this evolving elegance, I think, is the only word that comes to mind here. It's like of adaptive theory. Yeah. So people like Dr. Gatenby's work and Paul Davies' work, these guys are.
I've read about this. Yeah.
Oh my God, they're so brilliant. And what they're seeing and doing, it's like you push back just enough of the tumor burden, and then you let the terrain swarm in and do what it was designed to do.
So cool.
And I am a terrain expert. They may be tumor experts. I also feel like I've had to learn and become a tumor expert too. But my real jam, my real passion, my real understanding is in the terrain and helping the tumor-focused experts have better success. Mm-hmm. Because you do need to hit both. You do need to address both, and you need to address both well. And that's what I think is so exciting, is why our community, our network is branching out above and beyond the preaching to the choir people who were like, I'm already into this. It's like this new cohort starting next week. I think I know 2 people that are coming in, and there's like 30 some doctors joining us. Many are conventional oncologists from literally every part of the world. So
this is the cohort of people that you're going to be training. So just to be clear,
this is the 6th cohort we're coming into in September 2022. And so
a little more than save your ass school anymore, I guess.
It is. Now it's like we're all saving each other's ass and all the thousands of patients we deal with ass. It's like pretty cool to see this expanding. And so to that point, that's what I've been focusing on. There's 3 sort of missions with the Metabolic Training Institute of Health. And one is build a network, which we've been doing successfully since January 2020. Really pushing this out there and training physicians on how to become trained experts and how to follow this methodology that I've really, I wouldn't say perfected, because I think it's always a work in progress. So that I'm always building upon over almost 30 years. Mm-hmm. Number 2 is to build the data platform and this expert systems to help take in all that data and evaluate it in a meaningful and actionable way, and speed up the process in which physicians can interact with it and see the information to know how to use it right away versus the hours and hours and hours it takes to evaluate every single patient. Right?
Sure.
It's not scalable in the way that it is now. And so we're getting much closer to making it very, very scalable. And this is very appealing to all the physicians, and all of these physicians who've been on this journey and been learning this way. They're helping create the rule-based engines because we now have tens of thousands of patients that we're evaluating simultaneously together. So the building out of this expert system is happening simultaneously. And then the other thing that's happening simultaneously is a 29-year vision of this, this residential integrative, cancer hospital and research institute that happens to be on a regenerative farm. And so to me, the soil inside and the soil outside are intimately connected. And if you ignore one, you topple the whole, so we can't get well. Our planet is very, very sick, and we have to co-heal, co-collaborate together. And so the intentional community and the intentional environment, where 75% of this campus is basically a regenerative agriculture, food, forest that is nourishing back the land, but also the people that inhabit that land, is really integral and have been part of this vision all along. So we have partnered with a group of experts in that arena, as well as in green building on this campus, and our actual physical campus space for just the hospital and the wellness center component are happening in Southeast Arizona. And it's a nonprofit venture. So we are definitely looking for this, and we're running a capital campaign starting in the fall to really start to ask for the millions that are needed. But people have been lining up saying, once you have a piece of land, we'll start throwing money at it. So we now can talk about that piece of land. Like, we now have the place for this 29-year dream to make manifest. And the vision, so amazing. It's not to stop there. It's the template. It's the prototype for what we expect to populate all far reaches of this planet.
So multiple centers like this all over the world is your hope. Absolutely. Right? Yeah. So, that's an amazing vision, and 29 years in the making. And I know you've been looking to bring, experts in lots of different fields, and not just in the alternative world, right? In the conventional world as well. So
you'd be shocked. I think people are always surprised. Like, in some ways, it's the conventional doctors that are making this happen. The very conventionally minded who have
they're seeing their success rates, right? So they know that there's other things out there.
They're like, something's not working here. I got to think outside the box. And they start to look, and they start to realize where we are and who we are. It's ironic that people who seem to be least interested in what I'm creating are my own colleagues, which is okay. I have no
That's
problem.
So interesting.
Well, I think that place, it's like, I've lived this for so long and seen this for so long.
Yeah.
That it's such a big, unbelievable undertaking that I think people are like, that's impossible. And all the people like, it can't be done. And I'm like the person who's like, get the fuck out of my way so I can get this done. And so that's what's happening. And as I'm pushing those sort of naysayers out of the way, other people are like, well, what's that lady up to? I'm interested. Yeah. Let's go hitch ourselves to that wagon. And so we really have made really amazing relationships with big academic institutions, with big biotech companies, with a lot of really well-known researchers and clinicians at the top of their game, at the head of big institutions in their fields, that would be no one would ever imagine them hanging out in a sandbox with a crazy naturopath, there's nobody. And here we are all together at the same table. There is no ego. There is no hierarchy. And we're all on a mission and a vision to change healthcare as we know it, and cancer care in particular.
Except that you're in charge. Just kidding.
Well, at least in the time, I'm the executive director of this, but I'm really good at knowing, networking and finding the right people.
Oh yeah, no,
I'm not going to be doing I'm bringing in the best of the best of the
best.
No,
I know. And look, we've been speaking about this I think since you started in 2020, right before the pandemic, and I'm so excited for what you're building. I know. The hyperbaric piece would be a part of that as well. And you've been involved with my colleagues talking about that. And it's a big vision, Nasha, but if anybody can pull it off, it's you. I just want to say that it's been so great to work with you over the last, many years that we've known each other, and mutual patients and all your colleagues that you've been training. And it just really feels like the beginning, for you and for what you've been developing. And, just this whole alternative space that really isn't all that alternative. It's just looking at data in a much different and a much more forward-thinking way. And in the world of health optimization medicine and practice, what we do, it's the same thing. We're looking to create the data sets so that people realize that if you do foundational work, doesn't matter if you have cancer or if you're the healthiest person on the planet, in quotes, you're going to do better. You're going to have more longevity. Your health span is going to be better. You're going to get less cancer. Yeah, we can get protocols to figure out if you do get cancer or if you do get injured or whatever along the way. So last question for you is, I think just more of a fun one or interesting one for me. We talked about the checkpoint inhibitors before. Like, what do you see? Like, what's like one of the more exciting things that you see in the next like 6 months or a year that's going on? And like other than the space that you guys are developing, like the integrative oncology world, like what do you see in the next 6 months or a year that we're all going to be talking about that nobody's talking about yet?
Well, first of all, I think definitely you need to get Dr. Elsaka on your show, because I think the work that he's doing, he's touching a lot of these things that are truly the innovators of where conventional and integrative oncology are going. And those involve things around the redox world, specifically to the therapeutic dietary interventions world, specifically to things like ferroptosis, which is an entire conversation in and of itself.
Define.
Ferroptosis is basically using the excess iron overload and iron storage in the body as a smart weapon against the cancer.
Nice.
And using that. And so things like that are, and then in partnership with combinations of these metabolic therapies, such as hyperbaric, photodynamic therapy, I think, is the hot topic of cancer right now that's happening, and intratumoral injection therapy, specifically with things like mistletoe, and even some of the low, like fractionated chemotherapies and whatnot. So those are what I see are becoming tumor treatments in the future. But what I also think is happening is that's very exciting to me is there's this partnership between the food and health movement that is merging in a really powerful way and sort of reclaiming all that big ag and big pharma have taken away from us, and finding the way where a lot of these sort of converted back, these conventional farmers realizing they need to go back to the old ways, and these conventional doctors knowing they need to do something differently. We're all finding each other and we're building bridges there and creating quite a force. So I think that's very exciting to me. And then I think finally, there's also a universal understanding that we need to care for our soul as much as our, as the tangible and the mental health crisis. I mean, longevity in the United States, as you well know, this is the 5th year in a row, is dropping compared to the rest. No one else is dropping. Either people are either improving or staying the same. We've been dropping every year for 5 years, and the scientists call it the era of despair, and we're dying from suicide and opiate overdose. And if that's not an indication of the pain we're collectively in, the cultural pain we're in, nothing is. And I look at that cultural pain as a cancer in our society and community as well. And there's huge movements happening in that field. I'd love for you to meet and know about the People Humans Are Good project if you don't know them already.
No.
And so what they're doing is they're like being me in the field of mental health, and helping chart and gather metrics of people's emotional triggers and traumas in order to help find out what therapeutic interventions may be best suited. Similar product here. And they started out in the psychedelic space.
Interesting.
And they started to realize you can actually get there without psychedelics with a lot of different interventions when you understand where someone's coming from and maybe what tools would fit them best based on that data. So those are the things I think I'm most excited about that are on the horizon that will impact all fields of medicine, but definitely the field of cancer.
Wow. I would love to talk about all of those in more detail, but I've taken enough of your time, Nasha. Thank you so much for being here and being with us. And your knowledge base is just so ridiculous. I love talking to you. It's it's so much fun. Where do you want people to go to get more information? So if they're clinicians and they're interested in getting your training, where can they go, or other information about you or your?
I think I'll funnel them into the hub of it all, which is mtih.org. And that's Metabolic Terrain Institute of Health.org, mtih.org. That's going to get them to everything I'm doing under Dr. Nasha World, writings, speakings, lecturings, all that. But also very specific into our trainings, as well as the vision of the network, the data platform, and the build out of the hospital. And we are definitely looking for help in many, many areas. So check us out, follow us, and stay tuned, because a lot of cool stuff is on the horizon.
Well, I'm excited to be on the journey with you and learn as things go what the newest and craziest and most amazing things are that are happening. And I need to know about all those things you said at the end of this talk that we can talk about later. So
Right on. Absolutely.
All right. Well, you have a great day. And thanks so much, Nasha.
Appreciate you all. Thank you, Scott.
Thanks so much for listening to this episode with Dr. Nasha Winters, as well as Dr. Scott Scher, yours truly. I really hope you enjoyed it. If you did, please like and subscribe below so you never miss a Smarter Not Harder podcast episode. This episode was brought to you by Troscriptions, the makers of precision-dosed pharmaceutical grade and physician-formulated buccal troches. Check them out at troscriptions.com, along with Health Optimization Medicine in Practice, a nonprofit organization that's training doctors and practitioners on how to optimize health rather than treat disease. Check them out at homehope.org.